Aishwarya Krishna. ഈ ഓൾട്ടേർഡ് പാസീവ് ഇറക്ഷൻ ടൈപ്പ് 1 ടൈപ്പ് 2 എന്ന് പറയുന്നത് നമ്മൾ ടൈപ്പ് 1
Okay, I think we will start. Okay, good evening, everyone. Respected Dr. Ajish Polsa, members of the Safe Dental Updates, and dear doctors. We welcome you back for our 27th Learn from Our Masters series organized by Safe Dental Updates, and it's always an honor to be here. So to begin, we would like to introduce ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education always ensures predictable outcome for dentists of all disciplines and abilities. Our organization is based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various workshops and webinars to enhance the skills of dental professionals and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is crown lengthening, given by Dr. Ajish Polso. To speak a few words about him, Dr. Ajish Polso graduated from Amrita School of Dentistry in the year 2010 and finished his MDS in periodontology from Mahatma Gandhi Postgraduate Institute, GDC, Pondicherry in the year 2015. Since then, he's practicing clinical dentistry in Alua and Ernakulam in his clinic with special focus on periodontology, implantology, laser dentistry, and biomimetic restorative dentistry. He's a specialist consultant in Believers Church Medical College and Hospital and many dental clinics across Kerala. His areas of interest are immediate or delayed implant placement with soft and hard tissue augmentation, biomimetic restorations with deep margin elevation, and smile designing with pink aesthetics. So without wasting more time, I would like to invite Dr. Ajish Polsa for today's presentation. So please.
Plug it on the Pulikkal. Just so presentation start. Yes. Yeah, good evening, everyone. Thanks, Dr. Shanu, for that wonderful introduction. Am I audible?
Yes, sir, you're audible, sir.
Yeah. Okay. There's a slight confusion, like, just give me a second. There was some problem with my charger. Now it is sorted out. Yeah. Okay. Yeah. Thank you. My screen is visible to everyone?
Actually, no, sir.
I think now?
Yes, sir. The screen is visible.
Yeah. Okay. So sorry for the slight hiccups. As Dr. Shanu has introduced, I'm Dr. Ajish Pol. And thanks for that wonderful introduction, first of all. See, as he mentioned, I'm a periodontist, but I'm a general practitioner. So this class is from a general practitioner's point of view for the general practitioners. Not going too much into the surgical aspect or into the procedural aspect. We have only 1 hour time. No? This is just going to be a very, very, very brief introduction towards crown lengthening. Few cases which I see and I encounter every day in my own practice and in my consultation practice, and few cases I have taken from my friends also. who are my fellow practitioners or periodontists or general dentists. So coming back to crown lengthening procedure, which is our topic for the day. So what is crown lengthening procedure? What is the so the teeth? As we all know, that all our teeth has got a crown and a root, and the demarcation is called the CEJ. So from the CEJ till the edge of the crown, it is called the clinical crown, not actually the anatomical crown. Am I audible? Actually, I'm not. Can Shanu give me a thumbs up? I mean, am I audible?
Yes, sir. You're audible, sir. Please continue. Even the
Well,
display is also fine, sir.
Okay. No, actually, whenever I don't hear anything, or I'm not able to sense any response from the crowd or from the host. That is why I'm not very used to presentations like this. That is why I'm stopping in between. Okay. Okay. Straight away, we'll go towards the indications of crown lengthening procedures. So briefly, we can classify the need for a crown lengthening. First, we have to understand which are the clinical situations where you actually require a lengthening of the clinical crown. So briefly, you can divide it into cases where you have a restorative need for placing a crown, or for a restoration, the crown needs to be lengthened, or aesthetic needs, like for an aesthetic purpose. Okay. So the restorative needs, what are the common restorative needs which we encounter in our clinical practice? If you want to increase the clinical crown height, lost due to a dental caries, a subgingival caries, a fracture, or a tooth wear. Okay. So as you all know, we need at least 4 millimeters of clinical crown. Means at least 4 millimeters of crown should be available to give a proper retentive crown. Only 4 millimeters are required because most of the dislodging forces are at the apex, along the apex of the tooth. And if you have 4 millimeters of clinical crown, then there is no need for a clinical crown length. But if you have less than that, it is best to lengthen or to make some more crown available for giving a retentive crown. And again, there is a terminology called ferrule. The concept of prosthodontists, they say that the restorative margin or the crown margin should rest on sound tooth structure. And there should be at least 1 to 1.5 millimeter of sound tooth structure between the restoration margin and the crown margin. Okay. So we'll just, okay, like such a case. So you can see this case preoperatively. There is less than 4 millimeters of clinical crown which is available for a crown. And we are straight away proceeded with the crown lengthening, and you can see the postoperative picture. This is after 6 weeks. Now, another indication is to access a subgingival caries or a tooth fracture or deep restorations or even perforations in the coronal third of the root. You see few cases. You can see this case. This is the lingual aspect of a right second molar. You can very well see, you can't even see the proper tooth margin here because of the caries. Now, early, I would have done a crown lengthening for this case, but especially this was the lingual aspect of the of a lower teeth. The attached gingiva or keratinized tissue is very less. And nowadays, as Shanuf mentioned in the presentation, in the introduction, I'm a biomimetic dentist. I don't usually practice or usually give crown and bridges, or how I manage a post-endodontic restoration is by doing a direct, or if required, an indirect restoration, an overlay, not a full crown. So even in this situation, I actually did a crown lengthening. I didn't do a crown lengthening, but I did a deep margin elevation and I restored the tooth. But If you want to give a crown for such a T, the crown lengthening is necessary. Now, this is one of my cases which I actually this is the what I done here is actually wrong, but still I want you people to see this case. This is again a class 5 KDs. Actually, this was a perforation during RCT, a buccal perforation extending till the furcation actually. But in this case, I didn't even raise a flap, but I removed the soft tissue with a laser. I did a deep margin elevation and I restored the tooth. This was done on the same day. But later, now, once I started preparing for my classes, I was going through a lot of literature. And you can appreciate clearly in this, see the buccal furcation is actually involved. And definitely later, this patient, I have to recall and review this patient. But ideally, what would have happened is, I would have actually initiated a periodontal issue here. You can see the entry of the furcation entry there. And I didn't bother about the emergence, a proper emergence profile of plaque control to be really difficult for the patient. So this is actually a case of surgical crown lengthening where you have to actually open up a flap, do some osteoplasty, and do a crown lengthening. Now, okay. Now another indication for crown lengthening is a crown proximity problem due to tooth tilting, which may lead to embrasure space concerns. Now we'll discuss a case. So this is the bite wing. This is one of my foreign patients who come down from UK. So she had, we don't have bite wings. So bite wings are not common in our place, but they take bite wings very regularly. And this bite wing was sent to me for a preoperative evaluation. She wanted to get a proper understanding about what all treatment has to be done because she had only less time here. So if you see here, what I want to stress here is, see, you can see restoration was done here, but there is a clear subgingival caries in relation to the second premolar, and you can very well see the first molar is tilted to that area. So actually what I feel was the dentist would have found it really difficult to do a proper contour restoration in this case. But what we have to do is we have to do a slight odontoplasty here and then proceed and do a proper subgingival restoration. And maybe this also requires some amount of crown lengthening, definitely. Or this case, or on the other side, on the left side, the second molar was missing and the third molar had actually tilted to that space. Now again, to do a proper restoration in this area is really difficult. So here again, like if she was a young patient and she had enough time, maybe we could have done some orthodontic uprating or something. But what I did was I contoured the mesial aspect of the third molar and did some osteoplasty in the interdental area, and we proceeded and did the proper contour restoration. All this were done by I do most of my cases I try to manage with a direct restoration because I believe it's always best to create a contour and contact and a definitive margin. If you can follow the proper isolation protocols and all, it's always best to proceed with the direct restoration than to do a indirect restoration. Because many times you don't actually know where are you giving the crown margin. Now, you have other indications like if you some cases there will be need to perform odontoplasty to improve tooth emergence and or eliminate incipient or class 1 furcation involvements. I think I've shown a case of this already. And finally, another indication is to relocate margins of restorations that are actually violating the biological bit. Yeah. This case, in this particular case, if you see very clearly, this lateral incisor is an immediate implant temporization. The crown was fractured and I proceeded doing an immediate implant and used the same crown as a temporary prosthesis. Now, this particular case, if you can see, all other teeth has got, the central incisors has got metal-free crowns. But whenever I see this patient, from the first time, there was constantly inflammation present in relation to the marginal gingiva of both the central incisors. And maybe initially I was correlating it with the local factors, and I was thinking it was because the patient is not maintaining properly. And I recall the patient to take an impression for the final processes, and it was the same. So I told the resident dentist, that is a consultation case, I told the resident dentist to actually do a cleaning and recall the patient. And this was after doing cleaning, and the patient was meticulously followed up after giving proper oral hygiene instructions. And this is the best result that we could get. And to be very honest, I was not much aware about the biological width violation concepts at that time. But now what I understand is this subgingival margin of the crown would have actually violated the biological width. We'll talk little more detail about biological width, and you will be surprised. I mean, generally we believe the biological width is around 2 millimeters. But this, if the biological width for this patient is 2 millimeter, this crown wouldn't have actually violated the biological width. But some patients will have variations. So most probably this patient must have a thicker biological width, maybe around 3 to 3.5 millimeters. But I discussed this with the patient, and patient didn't seek any treatment. So we just because and again this is a consultation case, I just finished the permanent crown for the patient, and I don't know what is the present situation. And this is a case where in which there was perforation on all the probably all the anterior teeth, buccal perforation due to root canal treatment. There was calcifications of canals, and when the doctor tried to do the root canal treatment, it has actually perforated the cervical third, just below the CEJ, it is perforated. And in this case, again, we had to actually open up a flap, do some crown lengthening, and do the perforation repair. So these are the different surgical indications of of crown lengthening. Now again, coming to aesthetics, wherever you have a clinically short crown or a gummy smile, and sometimes the senates of the gingival contour will not have any harmony. We'll come and discuss some cases in detail in this section. How to okay, how to close down this chat. In my screen, this something is popping up, so that I'm not able to visualize the whole slide. Okay. ഡോക്ടറെ അതെ ഫുൾ ഇത് കാണാൻ പറ്റുന്നില്ല. അത് ഈ എന്താ പറയാ, അതിന്റെ മേളിലത്തെ ആ പോപ്പപ്പ് ഇല്ലേ, അതിങ്ങനെ ക്ലോസ് ആയിട്ട് നിൽക്കുക. അതിന്റെ പൊസിഷൻ ഒന്ന് മാറ്റാൻ വേണ്ടിയിട്ട് നമുക്ക് ആ സ്ലൈഡ് മൊത്തമായിട്ട് വായിക്കാൻ പറ്റുന്നില്ല. ഞാനൊരു കാര്യം ചെയ്യും, ഞാൻ സ്ലൈഡ് ഇതൊന്ന് ചെറുതാക്കാം. ഇപ്പൊ ഓക്കെ അല്ലേ? കേൾക്കാമല്ലോ? Okay, sorry for that. Actually, this some pop-up was coming on top, so that I was not able to see the whole slide. Now, see, we may think like, okay, this like during my practice also, during my early time of my practice, most of the crown lengthening cases, I just do a gingivectomy, either with a scalpel or with a laser. Okay, I don't have electrocautery with me, so I either use a blade or a laser. But later, when I started learning more about this, what I understood is, so okay, we'll just discuss this chart. So now either the restorative margin is within 4 millimeters of the osseous crest, or if it is more than 4 millimeters of the osseous crest. If the restorative margin is within 4 millimeters, you will violate the biological width. So anyway, you have to open a flap, do osseous surgery, and some amount of odontoplasty if required. Now, mostly what we do is, for all the cases where the restorative margin is more than 4 millimeters from the osseous crest, we just try to manage it with a laser or a scalpel without actually opening a flap. Now you see, there are only very few indications or very few clinical scenarios where you can actually manage with just a blade or a laser. Now, if you have an osseous ledging, means the osseous contour is, there is a ledging, then definitely, even if you have enough of soft tissue, but in order to get a proper flap adaptation, you'll have to open up a flap and do some osteoplasty. Again, if you want to adjust the emergence profile, or if there is any furcation openings nearby, crown proximity problems, all these cases you can only correct by actually opening up the flap. So there are only very few indications where you can only manage the case by doing a simple gingivectomy. Now coming to, see, now because it is my focus is more about aesthetic crown lengthening, our discussion will be most of our now as I told you, all these scenarios what we discussed early, either we do a direct restoration or an indirect restoration or a prosthetic crown. Now, as we discussed in our early section, whenever you don't have 4 millimeters of clinical crown remaining, and if you want to give a crown, you have to do a crown lengthening. But giving a crown is slowly becoming obsolete nowadays because of the improvement in the aesthetic dentistry, improved bonding protocols, isolation protocols, and all. So if I get a case like that where you don't have enough this 4 millimeters of clinical crown, nowadays what I do is to give an overlay, a bonded restoration. Or in a case where you have a deep subgingival caries, instead of actually doing a crown lengthening, I'll try to do a deep margin elevation. Okay, so some cases may require deep margin acquisition, but being a periodontist, I follow a simple motto: try to preserve the soft tissue as more as possible. Okay, so I always try, in whenever you have a subgingival caries or a class 5 caries which is subgingival, or a proximal caries which is subgingival, or a fracture which is going subgingivally, I always try to manage it with some kind of deep margin elevation or tissue retraction procedures. Okay, so I tried all these cases which we showed was the cases which I did in the early state of my practice. Now what I do, but the the need for crown lengthening is ever more relevant in the cases of aesthetic crown lengthening. So smile designing and this Hollywood smile and all this stuff is becoming very popular nowadays. So the soft tissue corrections has got a very major role here. So the rest of our discussion will be mainly focused on aesthetic crown lengthening procedures. So coming to this, first we have to understand certain clinical parameters like the width of attached gingiva, the biological width, the crown width to crown height ratio, the clinical crown width to height ratio, the relative position of the gingival zenith, the mechanisms of tooth eruption, how the tooth actually erupts. There is something called passive eruption and active eruption. And then the osseous topography. I mentioned early, the underlying bone morphology is also very important. When you have a ledging bone ledging or interdental osseous craters, that has to be attended. Now, again, our another focus will be how to diagnose a gummy smile. A patient will come and tell you, more of my gums are seen. The gums are seen while smiling. But you have to actually diagnose what is the reason for the gummy smile. Now, there is a classification put forward by Ernesto, which will actually help you to formulate a treatment planning for aesthetic crown lengthening. And finally, we'll discuss what are the treatment options for aesthetic crown lengthening. So we'll see one by one, the understanding the clinical parameters. First is the width of attached gingiva. This is a very simple concept. Now, you have gingiva and you have alveolar mucosa. Okay, so the marginal gingiva, you have marginal gingiva, which is present around the sulcus of the teeth. And then you have attached gingiva, which is tightly adhered to the periosteum. And then you have the lining mucosa, the alveolar mucosa. The junction is called the mucogingival junction. So the width of marginal gingiva and attached gingiva together is called the keratinase, the width of keratinase gingiva. Whereas that minus the marginal gingiva is called the width of attached gingiva. So why is this important? So whenever we do a crown lengthening, after doing a crown lengthening procedure, there should be at least 2 millimeters of attached gingiva left. Okay, so the attached gingiva is you require attached gingiva. That is, the alveolar mucosa is very less resistant to trauma or to even to toothbrushing or any kind of mechanical this thing for that matter. So you require at least 2 millimeters of attached gingiva remaining after crown lengthening procedure. So what will you do if you don't have that much attached gingiva? You know, the width of attached gingiva is different in different areas of mouth, especially like lower premolar areas and all. The attached gingiva width is very less. So such areas, instead of just doing a crown lengthening or a repositioning flap, you have to do something called an apically repositioned flap. I mean, instead of doing an undisplaced flap, you have to apically reposition the flap. We'll discuss about that. So the width of attached gingiva, you should have a clear understanding about the width of attached gingiva before starting the crown lengthening. Now, biological width. See, I'll try to make it as simple as possible. This is something which is very confusing. So what you have to understand is, see, the periodontium consists of the alveolar bone, the cementum, which is the alveolar bone. The tooth is in the socket, so the root is covered by cementum, and the whole thing is surrounded by gingiva, protected outside by gingiva. And the bone is connected to the cementum by periodontal ligament fibers. Now, this is covered by epithelium. I mean, covered by the gingiva, which has got connective tissue and epithelium. There are a lot of connective tissue fibers present in the gingiva, but what is relevant here is the connective tissue fibers which are actually attached to the tooth surface. These fibers are called Sharpie's fibers, And then the epithelium, there is an outer epithelium, okay, and then there is a sulcular epithelium, and there is a part of epithelium which is actually adhered to the root surface, okay. So this epithelium, this junctional epithelium and the connective tissue fibers attached with the root surface. So whatever part of the gingiva which is actually adhering to the tooth structure is called the biological bit, or we call the attachment apparatus, or the epithelial attachment. So this connective tissue is almost 1 millimeters in width, and the junctional epithelium is 1 millimeters in width. And the sulcus step, the gingival sulcus, is again 1 millimeter in width. So this is what we mentioned earlier. So the biological width is average. The average biological width is 2 millimeters in not in most of the patients. But this is the old concept. Now, according to Vachaka and all, there can be variations between 0.69 to almost still 4. For some people, the combined width of this junctional epithelium and connective tissue will be almost near 4 millimeters, as I showed you in one case before, where even encroaching 1 millimeter in the surface has actually violated the biological width. So how to check the biological width? Okay. Now this first photo, a periodontal probe is just kept. Okay. This is, I'm not going into the sulcus. Now with slight pressure, I'm taking the probe inside the sulcus. Now we can see almost 1.5 millimeters. And one more thing which you can appreciate from this picture is, you can actually see the marking of the probe through the gingiva. This is how you can identify the biotype of the gingiva. So if you keep an instrument inside, and if you can see the marking, or if you can see, this is see through, that patient has got a thin biotype. And if you can't appreciate the instrument, then it is a thick biotype. Now, coming back to our topic of relevance, now you can see almost 1.5 millimeters of sulcus. So this is the sulcus step. Now, what you have to understand is, now when you did this probe has actually gone through the sulcus and it would have touched the junctional epithelium. Okay, so the tip of the sulcus is touching the junctional epithelium, and the side of the one side of the probe is touching the sulcular epithelium. Okay, and many times this junctional epithelium coincides with the cemento-enamel junction also. Now, how to identify the biological bit? Now, forcefully you penetrate the probe till you hit the alveolar crest. Now you can see here it has gone almost 1 more millimeter. Okay. Now this is the biological. So if you reduce these two measurements, if you reduce this sulcus depth from the depth till you hit the bone, you'll get the biological width. So don't blindly follow 2 millimeters, but try to do this procedure is called transgingival probing. Now we discussed about the width of attached gingiva and biological width. Okay. Now what is the relevance of biological width? Okay, so we have heard about this biological width a lot of times. So see the symbol, don't think much. It is a sacred area. Don't violate this area. Whenever you do a crown or a restoration, try not to violate this area, especially the connective tissue attachment. Sometimes when you do an impression procedure or even do some tissue retraction procedure, you actually sometimes you injure the junctional epithelial area. But if that inflammation, if there is no continuous insult, it will automatically heal. But if you actually violate the connective tissue component, that will actually lead to further issues. There is a lot of more to talk about biological bit, but that will be too much. But simple thing is there is a part of the epithelium which is attached, which is actually attached with the tooth, and this is almost 2 millimeters generally. For some people, it may be even more. Try to measure that and try not to violate that area. So if whenever you are doing a coming to crown lengthening, whenever you're trying doing a crown lengthening, if you should not actually reach the area of biological this epithelial attachment. Whatever soft tissue excision you can do within this range, but below this level, never. If you want to go below this level, you have to actually open up a flap and reposition the alveolar crest so that you get enough width for the biological width to be recreated. So whenever you open a flap, you do the osteoplasty and you close the flap, automatically the connective tissue and the epithelial attachment will reform. Okay. So if by doing an excision, if you have a chance, by doing the excision, if you have a chance to actually reach the biological width area, don't do that. Okay. Now the crown width ratio. So this crown has got a width of almost 9 millimeters, 8 millimeters, and a height of almost 9 millimeters. Now, see, coming to crown width ratio, the general crown width ratio of width by length ratio is almost 0.78 to 0.85. Means almost the central incisor has a width of 8.5 millimeters and a height of 10 to 11 millimeters. This is about central incisor. This is the actual ratio of the clinical crown of a central incisor. Now coming to canines, the width and length will mostly be the same. The width and length will be equal, or width can be slightly less than the length also. Okay. Now, when you see this, always check for the clinical crown. Maybe the edge can be treated, or the crown margin can be receded. Take into account this also. Now, the relative position of the gingival senate. This all of you know that the when you draw a line touching, extending from the margin of the canine to the central incisor, it will be aligned. It will be on the same level, and the lateral incisor will be usually 1 mm coronal to this, line touching the centrals and canines. Now, this is something that we learn, or we just follow. But what you have to understand is, whenever you have a patient, if according to smile designing concepts, whenever you have a patient, which especially female patients with a high lip line, it is generally pleasing to have the lateral incisor margin equal to the central incisor and canine. Even if you have all the margins aligned, it will look okay. So you see this case, when we draw a line between this canine and this central is at the same level. But, and again, both the corresponding teeth should look like mirror images. Both the zenith of both the centrals should be at the same level. The zenith of both the laterals should be at the same level, and 1 mm coronal to this, and both the canine zenith should be at the same level and corresponds to the zenith of the central incisor. You can see a lot of discrepancies in this case. This right central is almost 1.5 millimeters coronal to the left central. Both the lateral incisors, the clinical crown length is very less. Okay, canines look okay. So just wanted, and again, you can in this area you can clearly see the width of attached gingiva. See, this is a mucogingival junction where the attached gingiva continues as the alveolar mucosa. So from this zenith till this demarcation is the width of attached gingiva, and this unattached part, or which forms the outer part of the sulcus of the sulcus, is actually the marginal gingiva. Okay, now coming to the mechanism of tooth eruption. Okay, see, when the root of the tooth develops, the tooth comes out of the alveolar housing. This is called active eruption. The tooth is erupting on its own. Now, this will erupt, and it will erupt the tooth will erupt till the CEJ. This is just an average value. The CEJ is 2 millimeters coronal to the osseous crest. Okay, the tooth is erupting out actively. Now, the tooth has come out and the CEJ is almost 2 mm coronal to the osseous crest. Now, what happens is the gingiva or the gums will recede in an apical direction, and this will stop at 2 millimeters above the CEJ. So, the teeth is not actually erupting on its own, but the clinical crown, the crown visibility of the crown is increasing by actually the gums receding down. Okay, this is called passive eruption. Okay, and you will have only generally you'll have 1 to 2 millimeters of sulcus. Okay, so from the CEJ, the gum margin will be 2 millimeters, and from the CEJ, the osseous crest will be 2 millimeters. Follow the 2 millimeter rule. Okay, so this is why we were discussing, when we were discussing in this flowchart, we told if the final crown margin is 4 millimeters from the alveolar crest, there is no need for any, you can clearly say there will never be any biological width violation. Okay, so this is another case of altered passive eruption, which I did very recently. Now, actually, sometimes usually this altered eruption, the patient's complaint will be aesthetic. But this particular patient, there was constant inflammation because of subgingival deposits. Okay, so this is immediately after scaling. So you can see the inflammation still present. So don't think that this altered passive eruption is just an aesthetic issue. There can be a periodontal issue also there. Now, see, this is a classification of altered passive eruption. So you have type 1 and type 2. Okay, so there are two parameters. Okay, and this APE is altered passive eruption and AE is altered active eruption. Now, if the alveolar crest is greater than 2 millimeters from the CEJ, there is no altered active eruption. The teeth has actually come out, actively come out to the normal level, but passively the gums have not receded to the ideal level. Okay, fine. Now, this classification is basically to help you in the treatment planning. The another thing which they have taken in account into this is the keratinization, the width of keratinized gingiva. So if you have less width of keratinized gingiva, it actually affects the treatment planning, because if you just excise this area, even if you don't violate the biological width, if you just excise this area, what will happen is there will not be an attached gingiva left out, and there will be inflammation always present there. So you have to, in such a case where the width of keratinized gingiva is less, you have to apically reposition this. Okay, and another thing what you have to take into account is if you have an altered active eruption, means the crest of the alveolar bone is not 2 millimeters from the CJ, but at or near the CJ. Okay, now you have to do osteoplasty. Okay, you have to remove this bone. Otherwise, even if you do a crown lengthening what will happen is it will regrow. Okay. Now, this is again the same thing. We'll just summarize how to treat an incomplete passive eruption. Now, the alveolar crest is within 2.5 millimeters from the CEJ, and the alveolar crest is okay. The alveolar crest is when the alveolar crest is less than 2.5 millimeters. What you have to see is the same thing what we discussed in there. You have keratinized tissue, adequate keratinized tissue, inadequate keratinized tissue. So when there is adequate keratinized tissue, again you have to see there is osseous ledging or not. Okay. If there is no osseous ledging, means see when the alveolar crest is less than 2.5 millimeters from the CEJ, there is an altered active eruption. Means the alveolar crest is nearer to the CEJ. So you have to do an osteoplasty here. But there is one indication where you can still do this without opening a flap. If you have a piezo with you, and there is no osseous ledging, okay, you can just make an incision and you can use piezo to remove the alveolar crest. But if you have ledging, means if you have more thickness of alveolar bone, if you do with the piezo, there will be a moat-like osseous moat remaining, and you can't effectively remove this with the piezo. And again, you have to contour the bone. Okay, you have to scallop the bone. So you can use a piezo here also, but you have to open a flap. Okay, so there is only one indicator. So if you have altered active eruption, but there is no osseous ledging, this is the only indication where you can simply do the procedure with the piezo without opening a flap. Now again, if you have inadequate keratinized tissue, okay, you have to finally do an apically repositioned flap. Okay. Now the other thing is altered passive eruption, where you don't have any alteration in the active eruption. Means the crest of the alveolar bone is 2 millimeters from the CEJ. Now again, if you don't have any osseous ledging and if there is adequate keratinized tissue, okay, no flap is required. Okay, because you don't have to do any alteration on the bone and you have adequate keratinized tissue. And even if you just excise with a laser or a scalpel without opening a flap, you will have enough attached gingiva, means 2 millimeters of attached gingiva remaining after the excision. So there is no need for opening a flap in this case. But as I mentioned earlier, such kind of scenarios are very less. Actually, maximum number of cases which people share in the social media, or which we do, which I have done in my practice, I have done like this. But in the end, you will recognize, see, many of you would have experienced whenever you do something like this and you feel like the tissue have regrown or rebounded. And sometimes you immediately give a temporary crown and you try to stop that tissue from regrowing, but again it will regrow. Okay. So this is what is because many times, even if you have enough amount of keratinized tissue, and even if the biological width is not violated, what happens is the alveolar crest or there is bone ledging. Okay, there is osseous ledging, and if you don't scallop or don't reshape this osseous ledge, when you this emergence profile, or there will not be enough height for a proper sulcus to form, gingival sulcus to form, and the tissue will regrow. And what you have to understand is, even if you open a flap and do a proper osteoplasty, then again the osseous ledge also has to be scalloped. Otherwise, again, when you close the flap, you will not get a proper aesthetic appeal. Okay, or sometimes even there will be pocketing. This is more relevant when you do a flap surgery, osseous resective procedure in a flap surgery. If you don't reshape the, you all of you would have we during our UG days we would have learned something called osseous resective surgery, and that is something we ignore totally. But in 90% of all the flap surgery, see, this crown lengthening procedure is also a flap surgery procedure. Any condition in which you open a flap is a flap surgery. So 90% of the cases you will require some kind of resective osseous surgery. Okay, many times when we do a flap surgery, there will be the pocket will not be eliminated because the bony ledges we are not removing. It is relevant in the case of crown lengthening procedures also. Especially when you're doing for an aesthetic this thing. Sometimes you will do proper crown lengthening with osteoplasty. Then again, the final result will not look good. That is because the osseous ledges are not corrected or not modified. Okay. Now, see, a patient is coming with a gummy smile. So you have to identify what is the reason for the gummy smile. See, you can't just do crown lengthening for all the cases. Okay. Now, there are different scenarios where in which you can have a gummy smile, like skeletal issues like vertical maxillary excess and tendoalveolar extrusion. See, vertical maxillary excess, when a patient smiles like this, when a patient smiles, they'll have gingival visibility. But if you see in this case, the crown root ratio is not altered. The height width ratio is not, the width to height ratio is not altered, especially in the central incisors. Okay. And if you see the typical feature of this patient, the lower facial third will be, when you divide the facial face into three, the lower facial third will be always more than the middle facial third. Okay. The lower facial third, there is vertical, whenever there is a vertical maxillary excess, the lower facial third will be more than the middle facial third. Now, dentoalveolar extrusion. This is very common in class 2, the typical class 2 conditions in which the mandible is retruded. So the maxillary anteriority, especially in vertical maxillary excess, the whole plane will be seen. Whenever you smile, even the posteriors behind the canine also, there will be excessive display of gingiva. But in the case of a dentoalveolar extrusion, only the anteriors, the premaxillary component extrudes. That is because there is no vertical stop. The mandible is retruded. Okay, in such case also, so when you see the dental plane, the anterior dental plane and the occlusal plane, in vertical maxillary excess, both will be coinciding. But in dentoalveolar extrusion, the anterior occlusal plane will be dipping down. So both of these are skeletal conditions. Maybe crown lengthening can be done to a very minimal extent. Okay. Now another situation is a dental issue where there is tooth wear with compensatory supraeruption. Whenever you have a parafunction or some situation where in which the edges of the tooth are worn off, the tooth will actually supraerupt along with the alveolar housing. So in this situation also, the clinical crown, the ratio will be altered. Okay, but you have to see the incisal edges. There will be attrition. Now another conditions are like issues with the lips. Either the patient has got a short upper lip, or some people will have normal length of upper lip, but they'll have hypermobility. Usually the lip almost 8 millimeters is okay between the rest position and maximum smile position, 8 millimeters of lip movements is okay. If the patient is having more than 10 millimeters, then there is hypermobility of upper lip. So when you have a short upper lip or a hypermobile upper lip, you'll have to do maybe some plastic surgery or some Botox or something. That is not in our hand. Now, coming to the actual relevant this thing, which is altered eruption pattern. Okay. Only where in which you have altered eruption pattern, like you can do some amount of crown lengthening in other cases also, but it will not solve the whole issue. And most of the cases will be combination of such factors. There will be some amount of vertical maxillary excess along with the short upper lip. Maybe there is some altered eruption pattern, but again there is maxillary excess also. Such cases, to some extent, you can do it. Or in some cases, see if the uh, visibility of the teeth is less, you also have to take into account the smile line. The visibility of the tooth is, if the lower lip is covering the edges, maybe you can remove, you can trim down from the edges and lengthen the crown if you have a favorable crown root ratio. So a few things you can do in such situations also, but you have to, what I'm stressing is you need to have a proper diagnosis why there is a gummy smile. Okay. So if you feel that is something that is not in your specialty or not something that which is beyond your expertise, you have to make the patient understand. Okay. Now this is a case of tooth wear with compensatory supraeruption. You can see this case. In this case also, this I think 2-1 was fractured, and no, the 1-1, I think 1-1 was fractured, and I gave that's an immediate acrylic temporary crown used as a temporary after implant placement. There was a fractured crown in relation to 1-1, and that was replaced. But why I wanted to show this case, this is a clear case of tooth wear with supraeruption. You can see the edges are trimmed down, but the teeth is erupted along with the alveolar housing. Okay, this is, there is alteration in the eruption pattern. Okay, and this is a simple case. This is there are only few cases where in which you can do this. You can do this. Here there was no alveolar ledging, and there was enough of, you see how much amount of keratinized tissues there, and there was only very little amount of crown lengthening which are required. So there are only few indications where in which you can just manage with the gingivectomy. Here I had used laser. You can do it with a scalpel or electrocautery, whichever way you want. Now this is the classification. Why this classification is important is because this helps you for the treatment planning. Now this is simple. There is class 1 to class 4. Okay. Okay. In this also, if you feel like if you see, some people do all the periodontal procedures by themselves. Okay. Some people call a periodontist for all the procedures. Some people try to do some procedures by themselves, and if they feel some procedures require some more expertise, they will call a periodontist. That is up to you. Okay. Now, anyway, you have to understand what is the situation. So the class 1, this is a treatment-based classification by Ernesto. So class 1 means there is sufficient soft tissue. Okay. And the gingival tissue removal is possible without alveolar bone exposure and without violating biological limits. So you can, whenever, if you like the case which we showed just before, This cases allows gingival tissue removal without alveolar bone exposure and without violating the biological width. And in class 2 also there is sufficient soft tissue. If you remove enough of soft tissue, it will not expose the alveolar bone, but it will violate the biological width. This is the difference between class 1 and class 2. In both these cases, any dentist can do the treatment. At least the first level of treatment, any dentist can do. Okay. But in class 2 cases, you require a flap reflection and bone reduction later by a periodontist. In both these cases, you can give an immediate temporary. Okay. So why you can give an immediate temporary is because you are not going to violate the biological width. Because anyway, okay. But if you this flap reflection and bone reduction, see, this is from a clinical point of view. A patient is coming there, okay, you're doing something like this, crown preparation or something. Okay, you have to anyway, especially if it is an anterior teeth, you can't send the patient without a temporary crown. So you do the crown lengthening, okay, you fabricate a temporary crown and give the patient, but recall the patient and do the osseous recontouring. See, if you are equipped to do the osseous recontouring, you can do it at the same time. Okay. Now, class 3. Class 3, there is no enough supraalveolar soft tissue. Okay. If it doesn't allow gingival tissue removal, so if you remove enough amount of gingival tissue, the alveolar bone will be exposed and definitely the biological width will be violated. So in such cases, the first place itself, you can't just do a crown lengthening and leave the patient with an exposed bone. Okay. So you have to start the procedure by reflecting a flap. Okay. Maybe later, see, whenever you do this procedure and when it heals, there may be later stage, you may require some slight gingivectomy, which you can do with a laser, or with a blade. You can do it on your own. Okay, fine. Now is the most difficult part. Okay, now all these situations, class 1, class 2, class 3. Okay, you have enough amount of attached gingiva. Now this is also not there. This is if you do a proper crown lengthening, the bone crust will be exposed and there will not be any keratin gingiva left. Okay. Now, such cases you require an apical repositioning flap. Okay. Or in some cases will even require a two-stage procedure wherein which you first increase the width of keratin gingiva by doing a subepithelial connective tissue, and later you can proceed and do a crown lengthening. Okay. For some cases you can do orthodontic extrusion also. You can either do a fast orthodontic extrusion or a slow orthodontic extrusion. I'm not an ortho expert, but I'll just tell the basics. So this classification is very important. Okay. In class 1 and class 2, there is sufficient soft tissue. And class 3 and class 4, there is no sufficient soft tissue. Means sufficient soft tissue means if you do a proper crown lengthening, the crown margin will not be exposed. Okay. And in insufficient, definitely the crown margin will be exposed. In between class 1 and class 2, class 1, no biological width violation. In class 2, if you do a proper crown lengthening, the biological width will be violated. So in class 2, class 3, and class 4, you require flap surgery. Okay. Fine. Now, coming to the treatment options. Okay, we are almost nearing the end of the presentation. We are reaching our 1 hour mark. So the treatment options, just to summarize the treatment options, You have surgical and combined options. Surgical options, there is a gingivectomy option. You can do it with a blade, with a laser or electrocautery. And whenever you need to open a flap, you have to do an internal bevel gingivectomy without osteoplasty. Okay, osseous recontouring. Okay, and if again if you have a less attached gingival bit, you have to do a apical repositioning flap. Again, depending on whether you want to do an depending on the situation, without osseous recontouring. Now there is combined approach, surgical and non-surgical, where in which you do a orthodontic treatment if possible. There is called something called slow orthodontic extrusion. Okay, see, whenever you apply some force on the tooth, whenever the tooth is moving, there is bone remodeling, right? So with a slow orthodontic extrusion, the tooth is extruding along with the alveolar housing. Okay, so later stage, definitely you will have to do a crown length. Okay, because the soft tissue or the bone will also grow along with the tooth. In rapid tooth extrusion, you're applying more force and the tooth will just jump outside. You should be very careful in doing this. But as you can anticipate, whenever you do rapid orthodontic extrusion, the procedure will be very fast. The actual the ortho movement phase will be very fast, but you require a long extended retention period. Okay. Now, before we also have to know the contraindications and limiting factors for crown lengthening procedure. So if there is inadequate crown to root ratio, because you're just removing the bone. Already the crown root ratio is not favorable. If you remove a bone, remove more bone, eventually your periodontally the teeth will become weak. See, if the teeth is non-restorable, there is a caries or root fracture. Okay, or if you want to do an RCT, there is a calcification or there is some other issue. Okay, then you should not go. There is no point in doing a root lengthening, crown lengthening. And if there is an aesthetic compromise, especially in anterior teeth and all, when you do a crown lengthening, especially in the interdental area, which will lead to a black triangle, especially if the patient is having a smile line, don't do that. Try to do some ortho there. Now, high furcation or short runs. If you expose that furcation area, you're actually creating a situation where in which there is a plaque. That area is very difficult to maintain. It will be a plaque retentive area. There is the predictabilities in it. You want to do all this means means you want to do some soft tissue grafting and a lot of complex procedures, and you don't know the predictability of the procedure. Don't do that. Okay. Now, if you compromise the adjacent periodontium or the adjacent tooth aesthetics, ortho is a better option. And if there is insufficient respiratory space, means even if you do a crown lengthening, if you don't have enough interridge width, what is the point in doing a crown lengthening? Okay, the patient will not be able to maintain that area. And definitely systemic factors, as you all know, systemic factors for any surgery is relevant here also. Now, this is the final chart. Okay. So for the tooth requiring crown lengthening surgery, now where can you do this? Is to summarize the thing. See, if the tooth can't be made periodontally stable, there is no way to extract that tooth. Okay. And if you can't restore it, then again, don't do crown lengthening, extract it. Okay. Now, if the tooth is restorable, but you can't treat it endodontically where it is required, extract it. It can be treated endodontically, but when you do a crown lengthening, if it compromises the adjacent tooth, okay, and in such a situation, ortho is not feasible or the patient is not willing for ortho treatment, extract the tooth. Okay. Now, when ortho is feasible, okay, you can do ortho treatment followed by crown lengthening. Okay, ortho is feasible, but there is no adequate attached gingiva. You have to do a soft tissue grafting followed by an orthodontic treatment followed by crown lengthening. Okay, this whole procedure will take almost an year. Okay, now if there is adequate keratinized tissue, again, okay. Now again, if it will not compromise the support of adjacent tissue, but again complex unpredictable therapies are required, then again extract the tooth. Okay, now again, if it's an indicated case, then again the same thing. If there is adequate keratinized tissue, just do a crown lengthening. And if you don't have enough attached gingiva, you can do a soft tissue grafting followed by a crown lengthening. Okay, so this summarizes the crown lengthening procedures. So again, to conclude, we need to know the indications for crown lengthening procedures. You have to understand certain clinical parameters like biological width of attached gingiva, the aesthetic concepts, the crown width ratio, and all those things. Then you have to evaluate a smile. Okay, you have to actually identify what is the reason. So if it is a skeletal issue or some other issue which require, or a issue with the lip length or hypermobility, the treatment itself is different. Okay, now choosing the right treatment plan is important, and you have to definitely understand where all you're not supposed to do a crown lengthening procedure. Now I would like to thank you all. Let those crowns be complete. Let them show fully. This is from the context of aesthetic crown lengthening. So thank you all for the patient listening. Now I think the session is open for discussion. I'm free to answer. I'm excited to answer your questions, queries. I'll try to answer it the best way possible. Whatever I know, I would definitely try to share with you. Thank you.
Thank you, sir. So if anybody has any questions related to the topic, please do post it in the comment section. So I think, so we have a few questions. Okay,
Yes,
so
yes.
the one question is, if you reach towards the connective tissue area,
Yeah.
bone contouring should bone contouring to be done?
Yeah. Actually, if you are violating if you're feeling that you're going to violate the biological width, you have to do bone contouring. This is more relevant whenever you're giving an indirect restoration, okay, especially a crown. Now, as I told you, if you're trying to do a direct restoration, okay, especially a composite restoration with a finished polished surface and a clear adhered margin, okay, without any marginal gap. Okay, this is what I personally follow, which is what I personally follow. I don't do a osseous remodeling, and this works for me. See, but again, I have to actually sacrifice the teeth, take a histological section, and see how it is actually. And again, it depends on how predictably you can do the treatment. See, managing a deep caries lesion. Okay, if you can isolate that area, if you can maintain a dry field, you can see that area, visualize that area. Okay, visualize that area. If you have the right armamentarium and time, and definitely I feel this is strictly my personal opinion. I can only tell you what I do. I don't do a osseous recontouring. Even if I reach the connective tissue part of the attachment apparatus. But if I'm proceeding with a indirect restoration, okay, if we do an overlay or something, what we try to do is we'll do a deep margin elevation, and this bonding of the indirect restoration will be at that area, at least will be with the direct restoration which we did by after doing a deep margin elevation. But when you do a crown lengthening procedure, a crown, when you do a crown, I don't do crowns, so I don't know. Like, and especially this verteprep is very common nowadays. So if you ideally use a special burr which doesn't actually impinge on the connective tissue. Okay, you have to ideally select a burr of the apical, the tip of the burr is non-cutting, no? So the tip, the diameter and the length of the tip should be actually selected according to the biological width of the patient. So to answer the question, if it is an indirect restoration, wherein which a cement is coming in that area, uh, uh, cement, you have to remove the excess cement, you can't see that area. Okay, it is better to do an osteoplasty, wait, give a temporary, wait for enough time for the biological width to re-establish, and then proceed and do the restoration. If it is a direct restoration under predictable situations, no, I personally don't do a osteoplasty. Hope I answered the question.
Okay, sir.
Hello?
Yes, sir. So the next question is how to stabilize an apically displaced flap?
How to stabilize an apically how to, okay, fine. See, whenever you are displacing a flap, first thing what you have to understand is you have to give vertical releasing incisions. Okay, vertical releasing incisions. And you should start by doing a full thickness flap. Then when you go more apically, it should be a split thickness flap. Means the periosteum will not be reflected from the bone. Okay, so towards the edge it is a full thickness flap, and but when you go apically it will be a split thickness flap. Means there will be a connective tissue attached with the periosteum, and there will be some connective tissue. You're splitting it, so there will be some connective tissue attached to the outer epithelium. Now you will be using this periosteum which is attached to actually pull down the flap. That is how you stabilize it. Okay, you use the periosteum. Okay, you have a split thickness flap and you have the periosteum, wherein which you take an anchor to stabilize the flap. Now, where will you place it? You place the margin of the flap at the new crest of alveolar bone which you have prepared. You've done osteoplasty and you reposition the flap in such a way the flap actually is at the crest of the new crest of alveolar, the crest, the after your osteoplasty, wherever your new crest is there, the edge of the flap is there, and you stabilize it by anchoring, by doing an anchor suture with the periosteal part. Okay.
Okay, sir. Is deep margin elevation flap raisal is sorry, is deep margin elevation flap is needed?
See, there are different ways to do deep margin elevation. Okay, there are different ways to do deep margin elevation. Actually, you just have to push that gingiva, whatever gingiva is coming in that your area of this. So there are different ways to do it. I mean, a flap is not, it is not necessary most of the times, or it is not required in most of the times. There is, if I want to discuss, if I go in deep about discussing deep margin elevation, there is a lot of techniques. There's a lot of techniques. The simple way to do is just to keep a wedge or to keep a Teflon. Okay, there are a lot of different ways, or to do a flow style. There are a lot of different ways. And personally, or the last resort is to open a flap. Open a flap and do an isolation with an open. I have cases where in which I actually open up a flap and I place a rubber dam, and then after that I replace the flap. That's such a situations also, I try to avoid removing bone. So to answer the question, deep margin elevation and flap is doing opening up a flap is not, the concept itself is different. But if you want to do osteoplasty, then definitely you have to open up a flap.
Okay, sir. So what should be the minimum age of the patient?
Or
Sorry.
there are just one thing. There are certain cases where you'll have an osseous crater. Osseous crater means you'll have a buccal and lingual peak of bone and a concavity in between. Okay. If such a situation is present, that is actually a periodontal defect. If such a situation is evident, then you have to open a flap and you have to or do osteoplasty in both in the interdental area. Otherwise, what will happen is a call, the interdental call. Okay. See, one more thing. I don't know. This is becoming a little more theoretical, but what you have to understand is, if the interdental tissue, okay, the soft tissue between the teeth, the interdental tissue is actually the inner part of the interdental tissue is actually coming and touching the contact point of the tooth, then that area will be mostly non-keratinized and concave in shape. Okay. So you ideally require a keratinized convex kind of interdental tissue or interdental curve. So you have to make sure that whenever you give a contour or a contact, there should be some amount of embrasure space. Means there should be a small black triangle. You should not make a very broad contact, so that the soft tissue, the inner part of the soft tissue will actually come and touch the contact point. There should be enough breathing space for it to grow in a normal way. Okay, a keratinized convex kind of interdental cowl is very important for disease-free periodontal, disease-free area. Okay.
Okay, sir. So I think we had come to the end of this discussion. So I will finally answer our last question. So
Yeah.
what should be the minimum age for the patient to do a crown lengthening procedure?
Mean age.
Yes, sir. Minimum age.
Minimum age. Okay. See, that depends on the vertical growth of the patient. Okay. So usually the vertical maxillary growth. Okay. See the the bone or the jaw grows in a horizontal direction, in a transverse direction, and in a vertical direction. And if my understanding is right, the vertical growth is the last to complete. Okay. And that completes early in females and later in males. Okay. So if you want to do a crown lengthening procedure, okay, so for a male patient, usually maximum 20 years their vertical growth will be, they will be done with their vertical maxillary growth. And in females, by 17 to 18 years, their vertical growth will be complete. Then again, there are radiographic measures. You can do hand wrist radiographs or cervical radiographs. As you all know, I'm not an orthodontist, but there are ways in which you can see, or you can actually confirm that the vertical growth is completed. And it is always best to do the vertical in any kind of crown lengthening, especially in the anterior aesthetic zone, after the vertical growth is completed. Okay.
Okay, sir. I think we had this one, the question answer session. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards crown lengthening procedure. So definitely many of us would leave this discussion with amazing takeaway points and implement technique as per discussed. So thanks to all the doctors who had participated for this webinar, and I hope all of you will depart this session with positive, confident manner. So to know more about our upcoming webinars and workshops, you can visit our Facebook page and our YouTube channel, as well as to check our previous webinars, you do visit our YouTube channel as well. So again, sir, thank you so much, sir, for your wonderful presentation. It was actually very informative, and I appreciate your valuable time towards your contribution. So thank you all.
Doctor. And if there are any more queries, you feel please feel free to ask in the group. I think I imagine there's a group, right, where they can.
Yes, sir. Yes, sir.
Yeah, anything. Or if somebody wants to ask anything personally, you can contact Dr. Shanu so that he can give you my contact if somebody wants to know more. See, actually, there are a lot of things in crown lengthening. I didn't go in anywhere near the actual procedure. How to do a flap design, how to do osteoplasty, how to do suturing. I mean, that will be too complex. And there are a lot of other aspects also, but I just try to keep it like very superficial. Okay, in 1 hour's time, this is the maximum possible. Okay, hopefully, maybe we'll be coming up with some other any like any further topics if required. If somebody is asking, like maybe we can come up with another discussion.
Okay, sir. Thank you so much, sir. It was very informative,
Okay.
actually. And thank you all, and have a great night.
Thank you. Good night. And happy Republic Day. Forgot I wanted to wish in the beginning, forgot. Okay.
Thank you.